Thanks for being here today. So in recent years, we've made remarkable strides in cancer. Innovations in precision medicine, immunotherapy, data science are transforming outcomes and giving patients new hope. But we should not lose sight of a critical truth. Progress that cannot be measured risks being invisible, and invisible progress risks being undervalued and ultimately underfunded. That's why today's panel is so vital. We're here to talk not just about advancing cancer care, but about how we quantify that advancement using data-driven insights to shape strategy, prioritize action, and drive accountability, especially in the face of competing priorities. But data alone are not enough. We need systems to collect and analyze it, political will to act on it, and sustained investment to maintain momentum, particularly when it comes to prevention. So with that, I'd like to start with you, Mark. And you've said that data eats opinion for lunch, which I love. I wondered if you could set the scene for us in sharing some examples of how data directly influences national cancer policy and shifts political priorities in a measurable way.
Thanks very much, Amanda. What I'm going to do is give you a few examples just from different areas that hopefully show you, one, that data is really the key aspect of how we use it, how we use intelligence. And I'm a big believer in using intelligence rather than opinion, no matter how expert that opinion is, to actually guide our true path in relation to how we look at cancer control. I'm chair of the International Cancer Benchmarking Partnership, and a couple of years ago, we did a study where we looked at cancer control policies throughout the world in terms of 23 different jurisdictions. And the reason why we did it, we wanted to look to see, do cancer policies actually equate directly with cancer outcomes? Because if they don't, then there's something wrong. So thankfully, we looked at 6 different cancers, and for each of those cancers, consistency of cancer policy aligned with better outcomes. So therefore, we had something to measure. And we developed what we call the cancer policy scorecard, and then scored each of the regions that we looked at in relation to that. So again, this was tough. It was tough for me. I'm from Northern Ireland. We were bottom of the table. But it was really important in terms of using that information. And the way we used it specifically in England, so for those of you who are from the UK, you may remember that just over 3 years ago, our Minister of State for Health at the time rather aggressively announced a war on cancer in England, produced a 10-year cancer plan and said, this is the way we're going to do it. He not so aggressively then, about a year and a half later, stepped back from that and very quietly hid cancer within a major diseases or major conditions strategy. We were obviously not very happy about that. So we presented this data. So I presented it in Westminster in the House of Commons to the Select Committee to show that essentially what they were doing was incorrect. And sometimes it's not easy to stand up and be counted, but you have to do it, because if you don't do it, then people just make decisions
Recording in progress.
based on something completely different than actual the data. And what we were able to do, and for example, we made sure that we got a coalition of the willing in relation to different organizations, each to present why it was absolutely necessary to reintroduce a cancer plan. Essentially, we've been 14 years of misgovernment by the previous government in relation to health issues and cancer in specifics. And thankfully, the new government listened. And so Wes Streeting announced, who's the Secretary of State for Health now, announced that a national cancer plan will be developed. So there's an example of directly using data, but it's where you apply the lever. And Vivek said at the start, levers are really important, and you need to apply the levers in the right place. This was the right place at that moment in time. Future cancer inquiries, so people were listening to it. A lot of committees, they don't necessarily listen to what you're saying. And so, and as well as that, Julie Graylow from the American Society of Clinical Oncology, I asked her, would she also participate? And Richard Price from ACO got her to be involved. So it showed that, the opinion was of that. So that's a great example of changing cancer policy at a national level. But sometimes you have to change cancer policy at a systems level. And a good example of that, and it brings in health economics as well, which is obviously of interest to The Economist, was the situation in England particularly, where if you were being treated for advanced metastatic colorectal cancer with a particular drug, you could not take a treatment break, even if your doctor said you should, because you were getting adverse toxicities. We thought this was completely unequal, an example of an inequality. And so we partnered with Bowel Cancer UK, or one of the leading bowel cancer charities in the UK, and presented 3 modes of evidence. One, the impact on whether you had intermittent or continuous cetuximab, so getting it all the time or getting it in doses and then having treatment breaks. And what did that do in relation to outcomes? It didn't have any impact in relation to negatively impacting outcomes. What did it do in terms of safety? It gave you more safe. What did it do in terms of patient testimonies? We presented numerous patient testimonies to show that this was much better for the patient. But the key piece of evidence that the National Health Service in England took on board was the fact that it saved them 1.2 billion. So again, sometimes it's what's the right piece of evidence that you need to present to the right organisation to get change. So one of the things I would suggest is don't be holding back in relation to providing evidence to support your point. Because as I did say, data trump opinion, even Truth Social.
Great. Thanks so much, Mark. That's really interesting. And I think that's an important overview from sort of that international policy and systems level. I wonder, Deepan, if you could build on this a little bit, because data is also important when we think about it in the clinic, at the clinical level. So as we see advances in the treatment of cancer, why is real-world data important, and how can it be used to drive clinical decision-making?
So real-world data is becoming now as important as clinical trial, phase 3 regulatory level data sets, because it's very important to understand how patients are doing after the clinical trial is completed in the real-world setting, how our efficacy and our safety is working out for our clinical trials, for our patients. So this is becoming a more important factor. And also on top of that, real-world evidence, you can also create something called synthetic arms to really compare and contrast different standards of care in different parts of the region to understand the real value proposition that we can make for our medicines as well. It's also becoming an important part for us because real-world evidence should be incorporated into regulatory filings. This was an approach started quite a few years ago, but still in a rudimentary level, which is try to take more into real-world evidence into our regulatory filings and also into our access pathways as well. Because finally, what we want to achieve is to make sure our innovative products get to our patients, and that is through the national access regimens. And there we need to be, the access regimens need to be more, in fact, adaptable to accept the real-world evidence. And that's going to be really important as well going forward.
Definitely. Thank you very much. We'll come back to some of those points. And Wolfgang, continuing on this thread of data, we often talk about improving data systems, whether at the policy level or the clinical level. But we talk less about the people behind those data systems. And I'm curious how we can ensure that investments in the European health data space also include sustained support for the human expertise, those analysts, epidemiologists, registry staff that are required to make these systems effective.
Yeah, of course, it's a very good question. So maybe I should just summarize in 1 or 2 sentences what European Health Data Space is before continuing just in a nutshell. So it's really a new initiative which started a few years ago and just earlier this year is now approved in Parliament for the European Council. And what it's all about is that really patients have the right to access their own data everywhere in Europe where they are. And they can also have a look and see who else is accessing their data, or to check if something is maybe wrong with them. So it's a really important thing to do. And as you can imagine, it will take a lot of time and effort to really make that possible in a room of, let's say, more than 450 million people. So it's a big undertaking. And yeah, and it will cost money. So right now, there is the situation we also heard earlier in the introductory speech that money is tight. Money is used also for other areas, not only health. First of all, it will be important to make sure that this really goes off the ground. There are many implications with it. A lot of things have to be set up, digital infrastructures, decentralized digital infrastructures have to be implemented. And yeah, there are many stakeholders. You mentioned a few. First of all, of course, there are the patients, and we need to be sure that beyond the funding of the initial funding of that initiative, there is money to improve on it and to make sure that it continues. And here, the member states of the European Union are really in charge. They have to do something here. But you also mentioned very important other stakeholders, doctors, physicians, but also data analysts. In the time of artificial intelligence, especially, when there is so much to be gained from using all these data, it's a massive amount of data which can help to not only to cure diseases like cancer, but also to prevent them, to see where are the hotspots, where are the risk factors, and so on, to make sure that all this is being analyzed properly and making sure that the data which are used are really of very high quality. Takes a lot of people and a lot of training. So yeah, at the end, it costs a lot of money. And the member states are asked for to continue with that support. But it will be a huge, huge benefit for everybody.
Yeah, it really sounds like it. And Nikos, I'd like to pick up on this this thread of money because I think that's on the top of everybody's minds these days. We know that the European Cancer Inequalities Registry provides valuable insight, but how can we move from registry data to enforceable action? And what concrete levers does the European Parliament have to ensure accountability and sustained investment, in particular, at the national level?
Yeah, that's at the heart of our discussions in the Sant Committee. I'm a member of the Sant Committee, which is a new committee in the Parliament for health. But can I just step outside the discussion for a second? Because I'm new in the Health Committee. And what Professor Lawler said, and I read some of his articles, I mean, he's producing the policies that we're following. So exactly what Vivek said about what's happening on the other side of the pond, science is going away from policy. He's helped make the policy. All of the people here helped shape the policy. And that's exactly what we're trying to do. So my participation here is to give some ideas, but also to take the proposals and see how we can implement them. And we are all, I look at it as one big animal with many moving parts. And I, as an MEP, is one part. Professor Lawler and Pfizer and Professor Luca from here is also part of that. So we need to put that all together. In terms of money, especially S&D, I have to say that since I'm the only parliamentarian, I'll praise our party, has pushed to put cancer high on the agenda, which means the new MFF, the new multi-financial framework, just to use the EU language, to include cancer very high. And we've asked a report to put cancer in much of the policies that are going on. And that includes, as later in the discussion, side elements, obesity, smoking, drinking. So we have a whole approach. But the main, I would say, result of this conference is exactly what we need to be doing in Parliament, to take your discussion and to then see how we can implement it. And I'm always impressed when someone who's a doctor, researcher, can also do policy. Supposedly, those are separate things. But here we have active doctors, active scientists who are also shaping policy. And I think that's something unique in our modern world. And so many people are working towards one goal, cancer, in so many different fields. The data equity is a big problem. For instance, Greece is making with a European-sponsored project called AI Factories, just means supercomputers. But we have no health data. We have no good health data. It's not collected properly. In Greece, for example, only in 26 will we have a uniform data collection for the hospitals. So we have inequities, and that's what we try to resolve in our party. Inequities between countries, within the country, rural, urban, those are some of the issues. And the money, we have to fight for it. Especially we're trying to introduce health as a problem of security because of the new security budget. We don't know if that'll go through, but we're thinking security has to include health somehow. Because that big budget, when I woke up and I heard von der Leyen saying 660 billion for, and I thought for cancer, but for defense. So you understand we need to shift that discussion a little bit, and the progressive group will try and do that. Thank you.
Really interesting. Thanks for that window into sort of the things that are on the top of your agenda now. I'm glad that you mentioned good data because I think that's really important to talk about what that means. And particularly with 20 million cancer survivors in Europe today, are we doing enough to measure outcomes beyond treatment, like quality of life, return to work, and long-term physical and mental health? And what metrics should be standardized across the EU to ensure survivorship is not an afterthought? That's to the whole panel.
Thank you very much indeed. And just to compliment Nikos on his thoughts there, and we very much support you as well. So anything we can do to help you in your mission in relation to cancer, we certainly will. I mean, I think we haven't. The 20 million survivors, we're not doing enough for it, to be perfectly frank. I think we've too much focus on treatment still. Treatment is an important part of cancer care, but it's not the only part. And we now have, in every country, we're going to have more cancer survivors than we had 10 years ago. So therefore, we need to be looking at what's the best way to look at that. And one of the things we really emphasised in the European Ground Shock Commission, which looked at cancer research in Europe, was the fact that we were doing very little research on cancer survivorship. And yet that's the critical thing, because we need to understand different issues than we do in the diagnostic treatment or the treatment paradigm in terms of the life after cancer and life during cancer paradigm. We're not really doing enough. So one of the things we need to be doing is having a particular European survivorship plan. I think it should be led by cancer, but also then should look at other diseases as well. But cancer should be the lead on that. And we need to be collecting those data from patients, so patient-reported outcomes. I'm extremely lucky that I work with cancer patients and cancer patient advocates all throughout the world. And uniformly, I can say the experience has been incredibly positive. But a lot of people don't listen to them. And they should listen to them, because what they're saying is actually true. And what they're saying is actually fact based on their experiences. And if we're not taking into account the experiences of patients and survivors, then how are we actually going to solve cancer as a problem? And we're not going to solve it. So we need to change our attitude in relation to how we consider real world data in the context of patient reported outcomes. And also we need to look at ways in which we can really address this in a way that we don't hide data. We actually have data out there. So if there is a problem in a particular country, you highlight it. Not just call it out and shame it, but to say, here's an example of good practice and how can we share this? So a great example is Denmark, I think, and I haven't been paid by anybody from Denmark to say this. If you look at Denmark in the year 2000, they had the worst outcomes and the worst incidence for cancer in Europe. But they decided to do something about it. They looked to see what were the difference. So they categorically went through each thing. They found, for example, radiation therapy, they had the lowest number of machines per 100,000 people. Cancer screening wasn't being done effectively. Breast cancer services were centralized. And now, if you look at it, and we've done this in the International Cancer Benchmarking Partnership, you can see the improvement in that period of time has been the best in Europe. They're not the best in relation to cancer outcomes and cancer incidence in Europe, but certainly the improvement has been phenomenal. So that shows that you can make a difference in a time frame that matters to people.
Just to add to the comment, in fact, so I fully agree with Mark, in fact. So we do study quality of life indicators and patient-reported outcomes in our clinical trials. But what we need to do, as Mark said, after the approval, as when the drug is out in the market, we just keep studying it to generate this data in a continuous basis. And this data also should be acceptable to our evidence generation bodies, including the HTA and access bodies as well. Today, we live in a world where access bodies still rely on clinical trial indicators like overall survival. Sometimes to generate these data sets are quite difficult, it takes a long time, and therefore access to our patients are quite limited. It's important to marry the quality of life and the patient-reported outcome data with good survival data into this, into the access part as well. Another important piece is in terms of generating these quality of life indicators. As Mark mentioned, we do have this data in all our hospitals throughout Europe. But it's very decentralized. It's kept by the hospitals, and even within a country, I know multiple centers and sites keep this independently. It's time to integrate these data lakes and start understanding this data. It's time for every country to start integrating with the European data lake so we could all access this data, understand the efficacy, effectiveness of our medicines, and then create true value for our patients in the future.
And that exactly is what the European Health Data Space should achieve. That's why it's made for. That really, wherever you are, in which country you are, if you have a healthcare provider, then you can go there into the database and look really at statistics, anonymized. You can do research on these data. Everything in theory then should be possible. Of course, that's a big plan. But I would also wanted to say that, especially because technology moves on, it's now really much easier than maybe a few years ago that patients can have wearable devices where they can check automatically, basically, how they feel, what's happening with them. And also that probably helps them to really continue to be involved in the treatment, even if they are called a survivor. Yeah, if they are then through these devices, for instance, are in constant contact with their cancer care providers, then they also feel that the whole process is just not finished. It's over. Nobody cares about them anymore. It's really ongoing, and their vital data help companies, help others. Research institutes to really continue making progress.
Please go ahead.
Just to add to that, here we come to a political element. In other words, we could talk about conditionality and EU funding if a country is not collecting its data, but otherwise that's also a problem to think of it like that. The Minister of Health in Greece, who's very active, conservative government, just said he's going to measure DNA of every born child and he's giving it to a private company to research. There was reaction from the progressives, but in the end, all those watches that we're wearing, I think of the AI world, all the things we're wearing could keep us actively involved in our health, which we're not really as individuals. We only think about our health when we have a problem. So we don't monitor it along the way. We do monitor it now, people who are healthy with all these blood pressures and health. So that would be part of an AI system. But again, you would find a political resistance on how much data we have to have with the GDPR and things like that. So that's the issue that comes to the parliament. How much are we allowed to use the data? It's anonymous, but you understand the political reactions to that. I'm in favor of doing it in an anonymous way because imagine the European health data space, the research that would come out of 300 million people with their issues and their DNAs.
Sure, Mark.
So 3 weeks ago, every person in Northern Ireland got their health data on their app, their My Health app. So Northern Ireland has moved from being sort of in the bottom of the digital league to being a trailblazer. So I think it's a Thomas Edison moment. And it's made a huge difference. So we're a population of 1.8 million. So that's small, obviously, compared with other countries. But now you can look at that whole population from a patient perspective, from a healthcare perspective, but also from a research perspective. And I think that's really important. We've also done a study looking at, for example, across the 67 million population of the whole United Kingdom in relation to looking at, under vaccination or not with COVID. So being able to look at things in populations is really important because it allows you to see, so even though, as I said, Northern Ireland is small, it shows you the spread of the whole population. Getting back to something else that Nikos just said as well there, it's really important that we make sure that we address the issues in relation to data protection proportionally. I have to say, I don't think we're addressing them proportionally. The country I was born in, not the one that I work in at the moment, Ireland, has a very disproportionate interpretation of the GDPR, and that is having an impact. I couldn't believe it. So I'm going to give you an anecdote, not mention the particular hospital. I was talking to people from a particular hospital who were trying to improve their clinical trial accrual rate. And I found out that the reason why they weren't moving any further forward on it, even though they had good practices, was that the data protection officer was essentially stopping it. And I said, well, do the data protection officers talk to each other because this trial is ongoing in this hospital here, and this hospital here? No, they don't. It's simply if one data protection officer interprets it differently, then that's the law. How can that make any sense at all? Doesn't make any sense at all. And I mean, patients say to me, they want their data to be, people who know me know that I present Jackie Gath, who's a breast cancer survivor who I work very closely with. And she said, and I use it unashamedly in most of the slides that I give actually in presentations, patients want their data to be used to improve their cancer care and to enhance research. In fact, they're often surprised that it's not used already. And that should be the way. And just a final point on that, we had to bend the rules in relation to COVID. So we had to look at ways in which we could diagnose the condition. So therefore, we had to relax the rules in relation to data protection in terms of diagnosing a COVID infection. Similarly, we had to relax the rules in relation to producing a vaccine. So again, we had to have access to personalized data. Did we have one single breach in that time? No. Did we achieve something that actually saved humanity? Yes.
Thank you. I think, this all sounds great in terms of integrated data sets, a singular platform, the advances in Northern Ireland. These are all good examples, but I can't help but wonder, how can we ensure for, maybe for countries where data literacy is lower, political will is lower, how can we ensure that these efforts don't create a digital divide issue with only some countries reaping the benefits?
I can take that if you want. But probably people want me to shut up. I think it's really important.
Start us off. Yeah.
One of the things that we've talked about a lot in a number of different groups in the European Cancer Organization is that whole health equity in relation to data. And I think it's incumbent on us as we develop the European health data space, we also make sure that digital literacy is part of that, so that education piece. What's interesting is if you take something that we've done in the European Cancer Organization, the European Cancer Pulse, which complements the European Inequalities Registry, what we've done is done launches within country. And that's been very effective, both politically, but also in terms of making people more aware. So what we do is we produce country reports for each country. We then launch the report in that country with the Department of Health or equivalent and the minister. And it's effective for two ways. One, sometimes it makes the minister sit up and take notes. So in Greece, as you know, Nikos, when we did it, all of a sudden there was talking about a national cancer plan. There was talking about national cancer screening. And similarly, in France, it highlighted inequalities in relation to breast cancer screening. Particularly in Bulgaria, there was an announcement straight afterwards in relation to HPV vaccination for boys. And so getting out there, walking the walk as well as talking the talk is a great way to get it on the political agenda, but we also need to get it on everybody's agenda from an educational perspective. And I think probably we need to do more in that space.
So it's worth maybe mentioning, like Pfizer, like other pharmaceutical companies, spend a lot of effort on medical education. More recently, we want to, in fact, make sure our research presentations at major congresses are understandable to the layman, in fact. So we always got a layman approach for all our abstracts, which we publish. And also going forward, this is something we also want to integrate with AI. AI is going to become a big focus of Pfizer Oncology, and we are trying to roll this out across globally to all our countries as well. And it's going to be built into our medical educational programs. But you bring a really good point. I think it's very important for our patients to understand the data set and also our clinicians as well to compare and contrast our data sets as well.
And if I can say a few words about inequalities. So on the one hand, you have these inequalities within a large area like Europe, but then also within countries, there are large inequalities. I mean, for example, in the city where I live in Berlin, there are huge differences. There are deprived areas where people live where they don't even understand their rights because they don't speak the language. Yeah, they have other risk factors which affect their chances of getting cancer. And the fact is that health insurers have, in principle, all these data available. They know them, they know all the patients by name. The problem in some countries, like in Germany, is that it's all fragmented. You have a lot of different databases. Other countries do much better. For example, Portugal does much better. They have a centralized database, and people can have a look at these data. So that is one problem what needs to be solved. And the other thing is really trying to reach these, let's say, underprivileged communities in a country to really and get them to pave the way to some comprehensive cancer center, for instance, for a center of excellence where people, specialist education on particular cancer actually work. And how you do that in a country where maybe there is none of these hospitals or maybe only one, and you have really patients living in villages far out is difficult. But maybe even now in today's time that people can do a lot of things remotely, that they can have access to healthcare and consultations and so on remotely. There are ways to address that, I think.
Interesting. Yeah, I absolutely agree. We're going to go to Q&A and actually, please, Nico.
Very briefly, I think that's the role about how to get these things going. Of course, we need to push on the inequalities registry and things like that. But in a sense, the conference like this, I didn't know this about Ireland. It was only 2 weeks ago. To have that presented in other countries, to take best practices, and then as a politician to hit over the head, either through embarrassment or through support or through money, to push it. And the Cancer Patients Organization, all these groups are in the end what push us to the next day, and that's what's happening, and that's what this conference is about, really. So I think it's a positive thing that we're together and we go to the next stage. And my way of thinking about it is lobbying has become a dirty word in a positive sense for these issues, whether in the parliament or in other countries. And you can do that in many ways, you can imagine. And some is just informational, some is including people in the health process, like the volunteer organizations. The only problem is you can never depend on volunteer organizations completely because it depends on the superstar leader. We have some good doctors they're doctors of the Aegean, so they descend with 10 inflatables to an island of 1,000 people. We have 200 islands like that, and they do the whole population. But if that doctor retires or dies, knock on wood, that process might disappear. So we depend on these champions, but we need to do more than that.
Definitely. Yeah. Thank you very much. We'll go to Q&A in just a moment, but one more question for the panel before we do. So be thinking about your tough questions for the panel. Someone mentioned it, but we haven't talked a lot about it, and that's prevention. And I think as we talk about data, collecting it and generating it is one thing, but what you do with it is really important. So the European Code Against Cancer is an evidence-based tool, but prevention still lags behind. What are the barriers preventing policy action on known risk factors like tobacco, alcohol, and obesity? And how can we overcome political inertia, especially when we already have the data?
I think one of the things is the amount of money we spend, or I should say the amount of money we don't spend on prevention. So we looked at it in the context of the European Ground Shock Commission. 4% is the budget for prevention out of the cancer research budget. So that's just not good enough. And I think the other thing is, we have the evidence in relation to tobacco. Dublin will be hosting the tobacco conference later this year, and I was talking to Kerry beforehand. So that's a great opportunity to highlight that in relation to that. But the other thing is alcohol. And, one of the things that the Irish Parliament has actually done, and it's got to the final session, is actually they will be the first country in the world to label alcohol in relation to a cancer-causing substance. And I think it's really important to get those messages across in relation to not just tobacco, but alcohol, obesity. There are a number of different things. And unfortunately, it's very difficult to get those messages across. And I think that's one of the challenges. It's not easy. And it needs to involve a multidisciplinary team with sociologists, etc. Why do people not go for screening? Why do people continue to smoke when they know smoking is going to? So it's not a straightforward problem, but one of the problems is we're not spending enough money on it.
Yep. Yeah, absolutely.
And on obesity, which is, of the three, I think it's the one that we could tackle the best because the lobby group is not so clear. Let's put it like that. And one obesity conference, one of the doctors said, we have no training in medical schools much about it, maybe a class. So in Greece, at least, it's almost an embarrassment to tell the mother her son is fat or overweight or whatever word you would use. It's actually culturally not allowed to make, and even now it's almost discrimination to tell somebody they're overweight. We're gonna have to be careful of the words. That we have to get past. So the doctor, especially the pediatrist, should be able to say, you're feeding your child too much, it looks like to me. And that's a danger for the future. That is not part of the culture. The cigarette and alcohol, we tried last year to pass reduction in alcohol, and the whole thing was whether it's 1 glass a week or reasonable amount. Well, what passed was reasonable amount. And for anybody, reasonable amount
could mean anything.
Could be 2 bottles of Dimples whiskey or so reasonable. It's a very nice term. And so that's a political issue. I think over time, the idea of labeling is very important. But that's a political fight. That's for us to make that argument. And that's not going to be easy.
Yeah, absolutely. I'll shift to a question online, and then I'll come to the room. So how can there be a shift in using retrospective data to make approvals of new drugs and medtech use versus using RCTs with primary survival endpoints?
So we touched on
Do
this.
you want to start?
That's for you.
No, we touched on this very important point, in fact, earlier on. I think it's critically important. Firstly, from regulatory purposes, there are two aspects, regulatory and patient access, the HTA people. And it's critically important. Both these organizations they understand the importance of quality of life indicators, real world evidence, our PROs as well, and how we can integrate that with survival benefit. So, for example, relying only on overall survival for cancer treatments, it's actually outdated now. We've got to start thinking of progression-free survival or overall response rate, and then marrying that with some quality of life indicators to create the value proposition for our patients. It's worth mentioning, I think at Pfizer, for example, we're investing around 40% of our R&D into clinical trials. And that's a critically important aspect for us. We're also coming up with new generation of molecules like the antibody drug conjugates, the small molecule inhibitors, which is the next generation drugs, including the bispecifics. All these drugs, in fact, will need our clinical trial network. Certainly, we need to understand through pivotal regulatory clinical trials, critically important. But we also need to understand the value of these medicines post-approval, but also what goes into it for our approval and access. So if you only rely on simple indicators like overall survival, which are slightly outdated in my opinion, compared to progression-free survival and also overall response rates, these innovative medicines can get in the hands of our patients much faster. And that's something we need to realize.
Thank you. Yeah, very interesting. Great. There are mics going around the room. Yeah, please go ahead.
Yes, it's working. Do you want me to stand up? I'm Peter Kapitein from Inspire to Live.
Yeah.
Mark said something very important. I'm a patient. I'm a survivor for follicular lymphoma for 20 years now. Had several relapses, treatments like stem cell transplantations. I produced tons of data. And as a kind of a statement, I uploaded my whole genome sequence into the cloud. And on real name, if you want to download my whole genome, download it and do research on it. Mark made a very important statement. Patients want their data to be used. I'm very much in favor of GDPR. GDPR was meant to have data used cross-border, and we didn't. Now we come up with something wonderful, European health data space, and it will fail if we do not attempt to make it possible to use. The problem is not patients. That's what Mark stated and what I state. We want our data to be used. It is scientists who keep the data for themselves until publication. It is industry who don't give the data free. 9 out of 10 medicines fail. That produces a lot of the important data. And the most important thing why data is not used is that privacy has become a business. Patients don't bother about privacy. They want the data to be used. If it's not for their own good, it's for the good of the patients that will follow. So please work together with the European health data space, because I'm a big fan of it, but work on that limited factors in the process of using the data. Mark, you said enough, but I think the people from Pfizer give some response on that.
So it's a good point, in fact. So let me say that I think from Pfizer perspective, and also generally in pharmaceutical companies, we publish our data sets. We do have a clinical trial data sets that we publish, and we publish both our positive data sets and our negative data sets in our congresses, and they're published in peer-reviewed journals. And that's already open. Where we are really lacking is actually some of the data which is already in the hospital setting. So for example, only 13 out of 31 countries in Europe publish their European survival databases in their countries. And it's critically important that we start publishing the hospital databases. That's what you're referring to as well. And then we can integrate these data sets, and then we can understand that further. And that's what we're asking for as well. And right now, it's very difficult to access the data sets because it's sometimes kept in single hospitals in a country or national registries, but not Europe-wide. And this is a gap which needs to be fixed.
Mm-hmm. Certainly. Thanks for sharing your perspective. Well, unfortunately, we're out of time.
I'll just take the ageism question there just before I'll just be very quick.
Sure.
So 11 years ago, I published it.
You need to read it, I think.
Oh, sorry, you can't see it. Can you not?
I'll read the question out. So approximately 60% of all cancers occur in people over the age of 65 years. Clinical trials exclude this group, and few oncologists are trained in geriatric oncology. What are your thoughts?
Yeah. So 11 years ago, I published a paper in the British Medical Journal called Ageism in Cancer Care. 11 years later, we still have ageism in cancer care. It's disgraceful. And it's going to get worse because obviously more people are getting older. So more people are going to need to be treated both in clinical trials and in just standard of care. So we need to do something about that.
Why is there ageism though? They don't want 65-year-olds?
Because they're looking at it in terms of the age rather than the frailty or non-frailty. So some people are above 65.
I think they're not.
Yeah, exactly. So it's not using a geriocentric approach. It's using it, they're too old, so therefore not. And I know colleagues of mine who've done that to my shame.
Thank you for raising that, because I think that's a really important issue. So now we have the big red clock on our screen here. So I'd love to keep the conversation going, but thank you so much for your time today. Really appreciate it.